Hello. Today I'd like to talk to you about a growing problem in Georgia, but really it's a reflection of a larger, broader trend that we see nationwide, and that's the increased suicide rate. And this has been going on for about the last 16 years. And as I stated, the trend actually, before the year 2000, had been reducing the number of suicides in America. But around the turn of the century, we started seeing it reverse and start upticking again. And this has been continued for the past 16 years to present time. It's critical to understand what is going on and what kind of variables are interacting and causing these issues before we try to address the problem. And it's important to look at it not just from an individual problem where we identify someone as at risk and try to determine what makes that individual have suicidal tendencies, but think of it more from a population health, a public health approach that addresses health concerns over vast numbers of individuals when we see trends like this. As I said, suicide has increased, is now the 10th leading cause of death in the U.S. across all ages. We saw a 24% increase in that rate from 1999 to 2014. And keep in mind, this is maybe the 10th leading cause of death, but it is also 100% preventable cause of death as long as we have the right resources, tools in place to address the issue. Males make up the majority of suicides, while females actually make up the majority of suicide attempts. This could be attributed to the method at which they do attempt suicide. Males tend to use firearms more readily, while females use either suffocation or poisoning, which would include taking pills as the most common method. We see whites and Native Americans have significantly higher rates of suicide than most other races. But when it comes to men and women, all men and women aged under 75 years old, from various age groups up from 10 all the way to 75, have seen an increase over the past 16 years. One of the concerns that we have seen is some subgroups that may not contribute to a large quantity of the overall number, but within those subgroups, the percent change has gone up tremendously. For instance, females aged 10 to 14, they don't contribute to a large total number of the overall suicides, but their rate has tripled since 1999. So why is this happening? There's no real easy, clear-cut consensus as a causative factor. But one way to look at it and think about it is by applying a social ecological model or looking at social determinants and how they interact. And this is a variety of things that happen from an individual level up to a societal level. So things like cultural backgrounds, belief systems, physical environment, socioeconomic conditions, societal views, community involvement, social capital infrastructure, how all these variables interact at various levels all can contribute to something like a suicide rate. And here's just an example of that in a diagram, and you can see there's a variety of variables at each level, and you can almost imagine a web of arrows interacting within the levels, all contributing to amongst each other and to an overall trend. And you can see how complex trying to pin down causative factors can really be. And just to give you an idea of just a kind of a basic example at each level, we look at the 5 different levels. On an individual level, something like clinical depression, that biological aspect of an individual can be a risk factor. While positive health behaviors, such as not being a smoker or drinker, no substance abuse, actively exercising, those types of health behaviors can be a beneficial factor. On the interpersonal level, if you've had a family history of suicide, it increases the risk of suicide for that individual. While strong family support, good open communication, knowing and you can rely on these individuals, that plays a beneficial role. At the organizational level, studies have actually shown church attendance is a beneficial factor for suicide prevention. It's not so much the type of religion you practice, but just having that support structure and knowing that that relationship is there for you could be a potential benefit. Whereas kind of the opposite of that, lack of counselor roles in schools or lack of counselors in places like workplace and prisons, not having that guiding voice in a time of need can be a risk factor. We take it up another level at the community. What are some of the local economic conditions? What's the job market like? If there's economic stressors in times of low unemployment, that can be an increased risk factor for suicide. Whereas something like the physical environment of, does this community support a lot of behavioral health centers? Are there clinical facilities readily available and plenty of access to care of mental health? That's a beneficial factor. At the policy level, incorporating mental health into kind of a national health care scene, which was actually done when the Affordable Care Act recently. That's a positive influence. Whereas something like gun control could be a positive or negative risk factor in terms of suicide, because some states have shown restricting access to lethal means, not just firearms, but that is a kind of an easily pointed out example, is a considerable risk factor. And one thing I noticed is you can't just pin down an idea of what a suicidal person is. This is why I was saying, you can't just look at it as individuals. A lot of people think of suicidal tendencies as somebody who's alone, maybe down on their luck economically, financially, not a lot of support around them. In just the last few years, there's been many very famous celebrities that have committed suicide that were doing very well financially, at the peak of their careers or in their particular fields, well respected, well liked, had lots of friends, lots of family. This might be an incident where it isn't so much that interpersonal organizational level, but maybe more of a individual level. Maybe it was a mental health issue in these individuals, but it is critical to understand that we can't pin down just a type when we think of suicide and how to fight it. Within Georgia, we see very similar demographics compared to the nation as a whole. We've seen growing suicide rates basically across the board, but some of the concerning areas are in those subgroups where we don't have a lot of total volume of the number, but just the percent increase within that group is very concerning. A 2013 Georgia Youth Risk Behavioral Survey showed 28% of high school students experienced a 2-week period of hopelessness during the past 12 months. 14% of surveyed students said they had considered suicide, and almost 10%, just under 10%, said they had attempted suicide in the past year. So when you start really thinking about these numbers, over 1 in 4 have had a 2-week period of hopelessness. That really hits home as how prevalent this really can be. So what are some proposed options? What can we do to actually implement an intervention? I'd like to suggest 3 today. Increased development and expansion of suicide prevention hotlines. This would include social media and digital support services. Incorporation of mental health into primary care in rural areas, and development of school-based awareness programs. When we think of suicide support lines, I'd like you to kind of broaden your thought of, instead of just thinking of traditional telephone crisis lines, while those are important and we need those, let's also expand it to develop text messaging services as well as social media outreach, a lot of methods that a lot of younger people use today. And I would suggest using Columbus, Georgia as a pilot city. You take a significant enough sample population, you have the technology and infrastructure there within the city, and provide a support outlet for those without those interpersonal or organizational social capital relationships. It provides an outlet for those that would not have one otherwise. And just to let you know, the National Suicide Prevention Hotline, it has got about a 15% increase in annual calls over the past several years. So it goes to show that the demand is there, the need is there. And actually a study showed that some state-based hotlines like this, they followed up with individuals that called and they did report a reduced feeling of distress, a reduced incidence of suicidal thoughts following their calls to these hotlines. The next thing I was going to talk about is the incorporation of mental health into rural areas. And this would basically be using county health departments and federally qualified health centers and providing their healthcare providers, whether it be a nurse, a counselor, a primary care physician, with some screening tools about how to identify some mental health concerns, even in their just basic primary care visits. In this case, I would suggest using Haralson County, Georgia. It's a rural county with nearly twice the state and national average of suicide. So it definitely shows the need is there, where we would train these primary care providers with the screening tools, develop quality assurance measures, and create sufficient referral networks. When we talk about school-based awareness programs, the key is getting counselors, teachers involved, and it's really about making awareness very, very open and letting people know what resources are available. As we said, we want to be very aware and target some of the younger generation, some of the youth who we've seen drastic increases over the past few years. This allows a variety of people, including an at-risk person's maybe just peers, other students, to be advocates for those individuals, to be people that can look for signs and symptoms. So how would we evaluate these programs? Well, we have raw data that we can take from national and statewide databases such as CDC Wonder, or Georgia has something called the OASIS system, and actually look at suicide rates, both attempts and actual suicides that are reported through ICD-10 codes. We would also want to do internal surveys and have kind of a more subjective feedback from providers and actual partners within the program, as well as the people that are at risk and benefiting from the program. We would need to do cost analysis of resources, not really evaluating, a monetary value on human life, but just of the actual resources we use and how can we make it more efficient, how can we use these more effectively. And it would be also good to do a cohort study during some of these things, such as the Haralson County rural mental health and primary care systems. When we have one group that did receive that intervention versus another that didn't, how did that impact it? So what are some of the outcome goals for this? What are we looking to see kind of longer term? We want to see success of these school-based programs and sufficient enough at the county level that we can standardize it to statewide programs, such as one that's already in use in other states is something called Signs of Suicide Prevention. We also want to broaden access to mental health care throughout the state. I talked about rural areas, but we want a really improved mental health safety net. We want statewide expansion of crisis lines and digital support services covering all geographic areas of Georgia. And basically, all this kind of boils down into let's increase awareness and supportive culture throughout the state to ensure that this remains a public health priority moving forward. What are some of the potential challenges, barriers? Well, funding is always one of them. These types of programs are going to cost money, but we can look into campaigning state legislators to allocate public dollars, also fundraising with community partners. We're also going to need some new policy development. For instance, school systems require passage of curriculum at school board levels to incorporate some of these programs. Also statewide, some of the governmental support things like Medicaid expansion would help with mental health. So we have to lobby and advocate at the policy level. Healthcare reform. As I said, some of these things really require a change in thought and philosophy across all of healthcare of how to address this issue. But I think one thing that's important is we don't look at these as individual programs, but a collaboration of a larger system. This was actually done in Georgia in the early 2000s when they developed the Suicide Prevention Action Network and came up with a Georgia Suicide Prevention Plan, but it really needs updated. We have the tools in place. We have the Georgia Department of Public Health and the Georgia branches of the National Association of Mental Illness that would be great partners for coordinating a variety of these programs. And we can see things such as the hotlines may be more considered a downstream intervention where you're getting someone at a real moment of crisis, whereas the rural health, the rural access to mental health care and the school-based programs are more of an upstream issue where you hopefully identify issues earlier on. And this is basically a logic model of kind of everything we've talked about today. We see the inputs of community organizers, media, Georgia government, the medical systems, and funding, and that all works its way through activities that expand our awareness of the problem, developing infrastructure, developing partners to help coordinate these interventions that we've talked about, and these same long-term outcomes that ultimately create the impact we're looking for of reversing long-term trends of rising suicide rates and continuing a future long-term focus on it going forward. I hope you've understood how important this is and gained an appreciation today of this growing trend and realize how much of a priority it really needs to be. Thank you.